All right, so low-grade lymphomas, low-grade non-Hodgkin's lymphomas, in fact. These are my disclosures. So let me start with this. So all of you should have audience response system. So I would like you to turn it on and answer a couple of questions. So essentially, this is a 58-year-old man who came to his primary care provider because he had right cervical lymphadenopathy. He was given a course of antibiotic, but the lymphadenopathy did not improve. So he did not have any fever or night sweats or weight loss. He received lymph node biopsy, and that revealed grade 1 to 2 follicular lymphoma, translocation 14-18. His CT scan of neck, chest, abdomen, and pelvis was negative for any lymphadenopathy or any other organ involvement, besides the one in his neck. Bone marrow biopsy was negative for lymphoma involvement. What would be your preferred treatment option? Involved site radiotherapy, R-CHOP, RCVP, or observation. Hold on, it is not starting here. All right. All right, so most of you think it is observation or radiotherapy. So Cataline trial showed that obinutuzumab plus bendamustine improves progression-free survival compared to bendamustine in patients with relapsed or refractory indolent non-Hodgkin's lymphoma who are refractory to rituximab. Or rituximab plus bendamustine improves progression-free survival compared to bendamustine in patients with relapsed or refractory non-Hodgkin's lymphoma. Or idelalisib improves overall survival compared to rituximab in relapsed or refractory indolent non-Hodgkin's lymphoma. All right. What do you think? So most of you think that rituximab and bendamustine improves progression-free survival compared to bendamustine in patients with relapsed or refractory indolent non-Hodgkin's lymphoma. So let's see. So how many of you have seen follicular lymphoma? Can you raise your hands? Perfect. So majority of you have seen it. So it is the most common indolent non-Hodgkin's lymphoma. It comprises 20% of all lymphomas. The tumor cells are derived from germinal center B cells, and they are characterized by CD20, CD10, BCL6, and BCL2 positivity, and they are negative for CD5. Almost all tumors have this translocation, 14-18. In fact, up to 90% of these patients have 14-18 translocation, which leads to overexpression of BCL2. As many of you know, BCL2 is anti-apoptotic molecule, and It primarily makes the tumor cells immortal. Most of the patients present with painless lymphadenopathy, they'll say, well, I have this lymph node in my neck. It is not going away. What do you think? Some patients may have B symptoms. They may have fever or night sweats, unexplained weight loss. And occasionally, you may have patients who have symptoms from organ involvement. For example, I saw one of my patients recently. He came up with left upper extremity swelling that was because of lymph node, which was in his supraclavicular area. It was huge. It was biopsied, and it was follicular lymphoma. And majority of these patients have advanced disease. Up to 70% of these patients have bone marrow involvement. How would you treat these patients? So treatment depends on many factors, including stage of the disease. It depends on comorbidities, B symptoms. But in general, for a stage 1 or contiguous stage 2 disease, these are treatment options: radiotherapy, immunochemotherapy, combined modality treatment, or observation. As a matter of fact, National Comprehensive Cancer Network guidelines recommend radiotherapy as the preferred treatment option. So we have a lot of experience with radiotherapy. Radiotherapy has been shown to have long-term disease-free survival rates, up to 40 to 50% 10-year disease-free survival rates with radiotherapy, which is fantastic. Dr. Arwani showed that survival rates with localized follicular lymphoma was similar for observation versus immediate treatment. Again, it was a retrospective study. Now, combined modality therapy has been shown to provide superior disease control rates compared to radiation therapy. However, we do not have a randomized control trial looking at each one of these options head to head, so we do not know what is best in terms of outcomes, long-term outcomes. So we decided to conduct this study some time ago, and we analyzed National Cancer Institute CR database. We looked at follicular lymphoma patients. We had a total of 28,000 follicular lymphoma patients. Of them, 6,675 had stage 1 follicular lymphoma that met inclusion criteria. We found that only 37% of the patients received radiation therapy. So only 1/3 of the patients end up receiving radiation therapy, even though radiotherapy is the preferred treatment based on guidelines. We looked at relative survival rates, and we found that survival rates were significantly better for radiation therapy group compared to no radiation therapy group. As a matter of fact, 1-year survival rate was almost 100% with radiation therapy compared to 96% with no radiation therapy. 5-year relative survival rate was 97% with radiation therapy compared to 88% with no radiation therapy. And the same thing was true for every subgroup. So clearly, radiation therapy showed improvement in relative survival rates based on this retrospective population-based analysis. Of course, it has its own flaws, as you know. So bottom line is only 37% of patients received radiation therapy, even though it is a preferred treatment option. Now, National Lymphocare study showed that only 27% of the patients received radiation therapy. So in general, radiation therapy is not being most commonly employed treatment for stage 1 or localized follicular lymphoma. Why is that? What do you think could be the reason? Nobody knows. But one of the reasons some people think is probably because there is no scientifically validated standard of care for early stage follicular lymphoma. So there is a need to compare each of these treatment options in a randomized controlled trial setting, head to head, and see which one provides the best outcome with most favorable toxicity profile. Some of these patients do not have any progression of disease over 5 years or 10 years. Why is that? So there is a need to develop biomarkers which can distinguish those patients who may benefit from treatment compared to those people who would not require who would require treatment. Now, how would you treat advanced disease? advanced stage follicular lymphoma can be treated based on the symptoms and based on the tumor burden. In general, patients who do not have any symptoms and who have low tumor burden, they can be given wait and watch or single agent rituximab treatment. There was a study published in Lancet Oncology last year. It basically looked at rituximab versus watch and wait approach in patients with advanced asymptomatic non-bulky follicular lymphoma. It was an open-label randomized phase 3 trial. So the patients were randomized to receive either observation or induction rituximab weekly times 4 or maintenance rituximab. And they looked at two things. They looked at time to start new therapy and quality of life at month 7. As you know, many of these patients, if you don't give them treatment, they're like, well, I'm anxious. The cancer is brewing inside me, and you're not doing anything. So that may impair their quality of life, right? And this is what they found. The time to start new treatment was substantially better for rituximab group. For maintenance rituximab group, it was 88% compared to 46% in watchful waiting group, and it was 78% for rituximab induction group. And in terms of quality of life, the quality of life was better for patients who received maintenance rituximab. So there was no difference in quality of life of induction rituximab group or versus watchful waiting group. So probably if you give them treatment for long periods of time, they feel better. So clearly, rituximab delays time to initiation of treatment. But question is, should we give treatment to every single patient? Because as you saw, almost half of these patients who are in watchful waiting group, who are in observation group, did not require any treatment at 3 years. And rituximab is not like holy water. It has its own toxicities. Some of them are fatal toxicities, right? Now, that is physical and emotional toxicities. And in terms of financial toxicity, as you know, chemo is very expensive. Chemo is not cheap. It costs tens of thousands of dollars. So question is, what are the risks versus benefit of giving rituximab treatment to everybody who had a stage 3 or 4 asymptomatic low tumor burden follicular lymphoma? So it is crucial that we have new biomarkers to identify those people who may not need any treatment versus those people who would benefit from treatment. And again, at this point, considering we do not have that info, we have to educate our patients about risks and benefits of each approach and help them make a good decision. How would you treat symptomatic or high tumor burden follicular lymphoma? So there are different treatment options. Rituximab-based treatment is the standard of care. You can utilize radioimmunotherapy. Now, idelalisib has been recently approved last year for the treatment of relapsed refractory follicular lymphoma. So, as many of you know, the rituximab pharmacokinetics depends on many factors, including age, body weight. So, question is does it impact the outcome in indolent lymphomas too? This abstract was presented in this year's ASCO meeting. Is rituximab suboptimally dosed in indolent non-Hodgkin's lymphoma? So it is from Cleveland Clinic. So they looked at, it was a retrospective analysis. So they looked at all of their patients who had indolent non-Hodgkin's lymphoma and who had received rituximab-based treatment. So they had a total of 303 patients. The patients were divided into 3 cohorts. One group received rituximab only, the other one received rituximab and chemo, and third one received rituximab chemo followed by our maintenance. They also looked at cohorts based on follicular lymphoma or non-follicular lymphoma histology, and they looked at event-free survival as the outcome. And that would mean treatment day 1 until relapse or progression or histologic transformation or loss of follow-up or start of second-line therapy or death. The patients were, all these three groups were well matched. As you can see, the median age was 63 years in our group compared to 60 in our chemo and 63 in our chemo followed by our maintenance. Median weight was almost similar in all these groups. Body surface area was 1.9 to 2. And almost half of these patients were men. And this is what they found. In follicular lymphoma group, elderly patients had better outcome in our chemo group compared to other cohorts. Similarly, patients who were heavier had worse outcome. The same thing was true for all these patients. So heavier patients had worse outcomes, and older females had better outcomes among our chemo-treated patients with follicular lymphoma. And it was not observed in our only or our chemo followed by our maintenance cohorts. So this difference in outcome was seen only in our chemo cohort. On my multivariate analysis, weight was found to be significantly associated with outcome. So something to think about when you gave treatment to these patients. So this is what they concluded. In patients with indolent lymphoma, particularly follicular lymphoma patients, outcomes among patients receiving our chemo is worse in heavier patients compared to patients who have lower weight. And it is better in older females compared to older males. The same effect was not observed in our only or our chemo followed by our maintenance cohorts. So this is their hypothesis. They felt that probably when you give weekly rituximab or maintenance rituximab, you exceed the therapeutic threshold and counteract the negative impact of higher body weight. So it is possible that a subset of our patients with follicular lymphoma end up receiving suboptimal doses of rituximab. Now, this paper was published recently by Ajay Gopal from Seattle and his colleagues. So they looked at idelalisib in patients with relapsed indolent lymphoma. They had included patients who had previously treated indolent non-Hodgkin's lymphoma. Most of them were follicular lymphoma patients. The patients had to have refractory disease to rituximab or alkylating agent. They had to have some measurable disease, and patient had to have good performance status, good kidney function and liver function, and hemoglobin of 8 or more, neutrophil count 1,000 or more, and platelet counts 50,000 or more per microliter. Patients were given idelalisib 150 milligram twice a day, and they were maintained until progression. The disease was assessed at week 0, week 8, 16, 24, and every 12 weeks thereafter. The patient received idelalisib therapy for a mean of 8 months, for a median of 6.5 months, and the range was up to 2 years. So the median time to response was almost 2 months, and median duration of response was almost a year. The median progression-free survival was 11 months, and overall survival was 20 months. The overall response rate was 57%, with 6% of the patients achieving complete response. If you count stable disease as response, almost 90% of them had some kind of response, which is fantastic for these patients who are refractory to rituximab or alkylating agent. And this is what they found. Majority of the patients handled treatment very well, except for diarrhea in 13% of the patients. They had grade 3 or more diarrhea, and 7% of the patients had pneumonia, which was grade 3 or more toxicity. So based on this data, FDA gave approval to idelalisib for relapsed or refractory follicular lymphoma. Now, Gadolin trial was the results were presented in recent ASCO. So they looked at bendamustine and obinutuzumab versus bendamustine in patients with rituximab refractory indolent non-Hodgkin's lymphoma. I'm thankful to Dr. Sain for sending me all the slides. So it was designed to evaluate whether combination of obinutuzumab plus bendamustine followed by obinutuzumab maintenance would improve outcome in patients with rituximab refractory indolent non-Hodgkin's lymphoma. As you know, obinutuzumab is type 2 anti-CD20 antibody. So it leads to increased direct cell death, but it causes lower complement activation. It is a better rituximab, essentially. So you have rituximab refractory CD20 positive indolent non-Hodgkin's lymphoma patients. They had 413 patients. They were randomized to receive either bendamustine or bendamustine plus obinutuzumab, followed by maintenance in patients who achieved complete response, partial response, or stable disease. And it was an international randomized open-label study. So the patients had to have rituximab refractory CD20 positive indolent non-Hodgkin's lymphoma with no exposure to bendamustine in the last 2 years and no exposure to monoclonal antibodies except rituximab in the last 3 months or any exposure to obinutuzumab. Patients were considered rituximab refractory if they did not respond to either rituximab monotherapy or rituximab in combination with chemotherapy, or if they had progressed within 6 months of completion of last dose of rituximab-containing regimen after at least 4 doses of rituximab monotherapy or 4 cycles of rituximab plus chemo. So the median age of the patients were 63. Majority of the patients were men, and majority of the patients had FLIPI low or intermediate risk. Beta-2 microglobulin was elevated in up to a quarter of the patients, and bone marrow involvement was present in a third of the patients. The mean time from diagnosis to randomization was over 4 months, and up to 10 lines of treatment that they had received. How many of you have given 10 lines of therapy to follicular lymphoma patients? Has anybody? I have not given, I see lots of lymphoma patients. I have not seen any patient where I gave 10 lines of treatment. It's outrageous. So, but median prior lines of therapy is 2 in both groups, and median time since last dose of last prior regimen was 4 and 3.7 months. So if you look at this, majority of the patients have follicular lymphoma in both groups, bendamustine group as well as bendamustine obinutuzumab group. And majority of the patients had disease refractory to our chemo. Now, at the end of induction, most patients had some kind of response, up to 69% of the patients. Around 10% of them had complete response, but majority of them had partial response. But at 12 months, up to almost 80% of the patients had some kind of response. So which was fantastic in patients who had received all kinds of treatment and they were refractory to all lines of treatment, up to 10 lines of treatment. So this was independent radiology facility assessed progression-free survival, and it was substantially better for patients who received bendamustine along with obinutuzumab compared to patients who received bendamustine alone. As a matter of fact, if you look at this median progression-free survival for this group, it is not reached at that point. And for bendamustine group, it was 15 months. Investigators assessed progression-free survival was better for bendamustine plus obinutuzumab. It was 29 months and 14 months for bendamustine group. The overall survival data as of now, there was no difference. So obinutuzumab plus bendamustine followed by obinutuzumab maintenance resulted in statistically significant and clinically meaningful progression-free survival benefit in patients compared with bendamustine treatment. And they did not have any major safety signals. So it may be one of the effective treatment options for these patients who may be refractory to rituximab. Of course, it is not approved by FDA yet, so keep that in mind. So now, finally, I want to spend a couple of minutes about histologic transformation. How many of you have seen histologic transformation in follicular lymphoma? It's bad disease. It's a nasty disease, very bad prognosis. Now, there is transformation to diffuse large B-cell lymphoma in these patients at a rate of 3% a year for up to 15 years. And for some reason, the transformation does not occur after that, and nobody knows why. But for 15 years, as you can imagine, up to 40–45% of the patients may end up having transformation, which is a huge number. So it is crucial that you talk to these patients about some, the red flags, like unexplained fever, weight loss, rapidly growing lymph nodes, and all that. And the lymph nodes which are rapidly growing, they need to be biopsied. PET scan alone is not diagnostic. You can utilize PET scan to guide the biopsy of a particular lymph node, but it should not be considered diagnostic. The median overall survival is 2 years, and it depends on, the prognosis would depend on the extent of disease and exposure to chemotherapy. If available, clinical trial would be the best option. Of course, immunochemotherapy, radioimmunotherapy, or stem cell transplant are other treatment options. So now, question 1. Hold on, it is not working. All right. So the first question, 58-year-old man with stage 1 follicular lymphoma, does not have any B symptoms. What is your preferred treatment option? Radiotherapy, R-CHOP, RCVP, or observation? Looks better. Perfect. So, Gadolin trial showed obinutuzumab plus bendamustine improves progression-free survival compared to bendamustine alone in patients with relapsed or refractory non-Hodgkin's lymphoma, indolent non-Hodgkin's lymphoma, who are refractory to rituximab. Or rituximab plus bendamustine improves progression-free survival compared to bendamustine alone in patients who have relapsed or refractory indolent non-Hodgkin's lymphoma. Or the idelalisib improves overall survival compared to rituximab in relapsed or refractory indolent non-Hodgkin's lymphoma. That's fantastic. Not too bad. Pretty good. Thank you so much.